lead audiologist of clinical services and director of the Vestibular and Balance Research Lab at Boys Town National Research Hospital. Her PhD was from the University of Nebraska, and she did a postdoc at Johns Hopkins University. Her research focuses on the effects of vestibular loss in children and special populations, and I've heard her described as super cool. So we welcome her. Let me, just before I let her start.
Well, I will thank Crystal Riska, who's on her way, for the super cool. We are just visiting her lab. Thank you, Emily. Wow. Okay. So I came up with a really generic title today because we're just going to talk about a lot of different things. So one of the things as I kind of start introducing myself is that as John did introduce me, I do clinical work, I do research work, and so I wasn't exactly sure what to talk about today. So I'm going to talk a little bit about how our research has impacted the clinic and hopefully send you guys home with some tidbits for clinical use and for research use. But first, I just want to say thank you so much for having me. I am a long way from home. So if I were to drive, which I did not, I flew, it would have taken me about 18 and a half hours and a little bit of construction to get here. But I'm happy to be here. And just to provide a little bit of feedback, come on in, everybody, of who I am and how I got here. I am married. If you have seen any of our vestibular videos online, you've already met my husband, Jared. I have two little kids, they're 4 and 6, who you will see lots of videos today, so I'll apologize in advance for all the pictures I show of my kids, but when you're a pediatric vestibular audiologist and you have 2 children, they come to work with mom and they enjoy it, and everybody gets ice cream when we're done. But how I got into audiology and vestibular is really from my brother. So I have 2 brothers who are shown in the picture on the right. I'm the middle child, but my older brother, Brandon, who's sitting next to me, was diagnosed with hearing loss when he was 3 years old, which is shown in the picture above. He lost his hearing because he got the measles as a baby. And they think that his hearing loss either occurred because of the measles virus or the medication that he was given as an infant. But either way, he has bilateral hearing loss. He wears a cochlear implant. He has a cochlear implant in one ear that he does not use because he got it when he was 30, and then has a corner audiogram in the other ear and wears a hearing aid. But he got me interested in audiology, and then in his 20s, began experiencing episodes of dizziness. And we were both living on the East Coast. I was in Baltimore and he was in DC. And my mom sent me to his appointments because he never reported back to her about how they went. So I was like, I will go be the scribe and then I will report back to you. And then also just to help ease communication in the appointment. So I went out to a few appointments with him as they were sort of determining the underlying reason for his dizziness. And interestingly, the physician who saw him at Hopkins ended up being my postdoc mentor. So it all kind of comes full circle. But that's kind of how I got here and how I got to Boys Town. So my brother was followed at Boys Town for all of his audiological visits. And when the opportunity arose for me to start there, I was like, yes, that just seems to make perfect sense that I would start my career where I have been going my entire life. So I wear 2 hats at Boys Town. I am the team lead for vestibular services, which means I oversee the clinical department. I also see patients in the clinic. And then I have a research lab here. So I'm the director of the Vestibular and Balance Research Lab. And we primarily focus on studying the effects of vestibular loss on children. And so we study all kinds of things from balance, visual acuity, reading cognition, quality of life, so on and so forth. And we're always looking for new ways to understand how vestibular loss affects children. So if anybody is interested in collaborating, contact me after the presentation. But part of that too, when you're studying children, is that we needed to understand who is at risk for having vestibular loss. So some of our studies have focused on, which cohorts of children we need to focus on in the lab. And then for children, age 6 months to 18, we had to figure out what are appropriate methods for testing kids. So some of our work has been, just pretty preliminary in terms of figuring out the best way to achieve vestibular results in kids. So clinically, I serve on 3 multidisciplinary teams. I work on our cochlear implant candidacy team, and as you can imagine, individuals who are seeking a cochlear implant will see a lot of different individuals, but I am one of those to do a pre-implant vestibular assessment. We have a pediatric hearing clinic. So for all children who are newly identified with hearing loss at Boys Town, they'll see a multidisciplinary team. And part of that is just understanding what their vestibular system looks like. And we sort of focus on how we can help determine the etiology of the hearing loss based on some of their vestibular results. And then we have a multidisciplinary vestibular clinic for individuals of all ages where we're trying to understand the etiology of their dizziness. And so they'll see me along with a neurologist, physical therapist, and then audiology for hearing assessment. Administratively, I'm in charge of leading the clinical program. So that involves, setting meetings, setting protocols, figuring out where our weaknesses are, and then, strategically advocating for our program. I also direct our T35 short-term research training program for students. So I've already tried to recruit a couple of you in the audience. Please come to Boys Town. I think we have a really strong T35 training program that's centered around increasing the amount of audiology students that go on for their PhD. We really, really need scientists in the field. And then I'm on our externship selection committee. And I just want to thank UNC as a whole for sending us really great students. You guys do a great job training your students. And so we've seen a lot of your students come through both our T35 and our extern program. And we generally know that if the students were trained here, they're going to be a good fit at Boys Town. So thank you. So what am I going to talk about today? I'm not going to talk about myself the whole time. We're going to talk about pediatric vestibular. So there are three things that I hope people take away from this talk. One is that most importantly, we'll address this first. What are the consequences of vestibular loss in children? That's the driving force. If there were no consequences from vestibular loss, we wouldn't care about testing them. So the first thing we're going to talk about is what happens when a child either is born with or has early acquired vestibular loss and why we should care. Two then is we're going to talk about 5 things you can do in 5 minutes to identify whether a child is at risk for having vestibular loss. And then I'll take just a couple of minutes to describe some new techniques that we're working on in the lab in terms of overall assessment and rehabilitation. So what is the vestibular system? Well, it's been referred to as the cochleus fraternal twin. Looks nothing like it, shares some commonalities, but really functions very differently. So we have 3 semicircular canals in our vestibular system, which respond to angular acceleration. And what is that? That means when I shake my head no or yes, fluid moves in those semicircular canals and decodes that type of movement. And then we have 2 otolith organs called our utricle and saccule, which basically sit in the shape of a letter T. Doesn't look like it on the picture, but that's how the sensory structures on the inside are situated. And their job is to decode linear acceleration and gravitational changes. So we have calcium carbonate crystals in there that either are weighed down by gravity or are pushed and pulled when we do activities of linear acceleration, like walking, riding in a car, or as I did, rode in an airplane on the way here. So the vestibular system decodes all of these types of movements and then sends that information to all the skeletal muscles in the body for 3 important reflexes. 1, to maintain steady vision during movement. So if everybody holds their thumb out, gives me a thumbs up and says, yay, I like vestibular. And then you move your head no, your thumbnail should stay steady during head movement. And that's that vestibulo-ocular reflex kicking in. So those semicircular canals decode that angular acceleration and keep vision steady during movement. That information is also sent to all the skeletal muscles to help keep us upright, and including the neck to help keep our head on straight. And so Peter Steiger sent me this video a couple of months ago, which I thought was a really neat depiction of how cool the vestibular system is for sort of maintaining a steady ride. So you can see that during all types of movement, the head is maintained nice and steady, and that no matter how we move, that vestibular system is decoding all of those movements to create synchronized movements among chickens, but just helps the body stay upright. So it reduces our risk of falling and then allows us to see steady during head movement. So if anything, I think the video is really entertaining. The purpose of the video is to try to get you to buy a Mercedes. So, I don't drive a Mercedes, but I imagine that it's a lot like having a refined vestibular system. So let's get out of here. What happens when the vestibular system isn't functioning? Well, it probably looks something like this. not driving a Mercedes-Benz. So this is what we see in a lot of individuals who have significant vestibular dysfunction, where we see falls, we feel off balance, and we're not driving very smoothly during our everyday activities. Let's see here if I can get out of this. Nope. Escape. Go here. Start over. Okay. So a lot of research has been done in adults to understand how vestibular loss impacts our everyday lives. So you can understand that if you're not seeing very clearly, or the vestibular system isn't decoding movements, that you might not see clearly during head motion, which is exactly what we see in adults. So they have what's called reduced dynamic visual acuity, which means that I can see fine if I'm not engaging my vestibular system, but as soon as I start moving my head, I have a lot of visual blurring. Just like the chicken that we saw, there's a lot of imbalance, there's increased falls, and there's a new line of research that's come out in the last 10 to 15 years that show that the vestibular system has some really important cortical projections and that you can have some cognitive dysfunction. So you can imagine that if you can't see while you're walking, you're off balance, you're falling, and you're having some cognitive changes, that you might have reductions in quality of life. So we asked the question, do children suffer from the same effects of vestibular loss as adults? And there was a body of literature early on that said, no, there's no way children undergoing these, large, time of gross development, high levels of plasticity. And so children are going to be, nothing like adults. So before we talk about kids, I'll just say that there are some important things to consider when you're doing pediatric research compared to adults, is that children, as we all know, they're not small adults. Adults, when we look at vestibular dysfunction, typically will acquire their vestibular loss as an adult. And so they have this pre-vestibular loss time period that they are grossly aware of. And then they remember that time point when the vestibular loss occurred, and then they know how their life was changed. So that is completely different than children who are either born with or acquire the vestibular dysfunction right away, in that they don't have this life experience pre and post. They only have the life experience with. Children also don't have the language with which to describe some of the symptoms that they might be experiencing. And without this pre and post life experience, they don't know that what they're experiencing is actually abnormal. Children are going through a period of exponential development as opposed to adults who are sort of on the decline, where they might be having some underlying components of aging. So it's really unknown how having vestibular loss interacts with that time of development. And then most importantly, and something we'll talk about, is that children have comorbid hearing loss. And that can't be overlooked as a contributing factor when we're trying to understand how vestibular loss affects, all different facets of their life. So I would say preliminarily, and what we'll circle back to, is that despite these differences between children and adults, preliminary evidence does suggest that children suffer from the same effects of vestibular loss as adults do. And that's sort of the primary emphasis of things that we focus on in the research lab. So I'll step you through some of the key research that has sort of led me to believe this. This was some work that Jennifer Braswell-Christie did at UAB. That showed that similar to adults, children with vestibular loss have reduced dynamic visual acuity. That's not surprising. If that vestibular system isn't working, it's not sending a signal to the eyes, there's no level of plasticity that's going to make up for that. So the way we typically will check that is two different ways, but the easiest way is to just have an eye chart in your clinic and you ask patients to read down to the smallest line that they can see clearly, and then you stand behind them and you shake their head. If I have a normal functioning vestibular system, I should be able to see exactly the same with my head still as I can with my head in motion due to that vestibulo-ocular reflex. But if I have vestibular loss, it's not uncommon. Do we have a laser pointer here? No. To have a 2-line loss of acuity. So let's just say that I can read at 10 with my head still. If I lose one of my balance centers, it's pretty typical then for my acuity to come in during head shaking roughly at like line 7. If I have no vestibular function, it's typical for my acuity to come in about 4 to 6 lines above that. So let's say up there at line 5. So you can imagine that it's really difficult to see clearly doing a lot of activities where we're moving, like playing sports or walking around in a classroom or doing something dynamic where someone calls my name. Or I had an older gentleman come in and say that he had a hard time reading signs while he was riding his bike down the boardwalk at the beach, and he had to stop every time he wanted to see clearly. We've done some work to show that the degree of vestibular loss is related to that degree of visual acuity loss. So we did a simple skill here to say so we have 5 rate sensors in each ear. 5 + 5 is 10. If all of those were working, then you got a 10. If none of those were working, you got a 0. And there's a nice linear relationship here where the less vestibular function you have, the larger print size that you need for reading during any type of movement. We also know that children who have vestibular loss have gross motor delay. So that vestibular system is supposed to send those signals to all the skeletal muscles to help keep us upright. In adults, that usually manifests as some degree of imbalance, but for kids going through that developmental trajectory, that impairs their ability to acquire certain gross motor skills. So typically developing children usually on average will sit at age 6 to 8 months, stand at 10 to 11 months, and walk at 10 to 12 months. But for children who have vestibular loss, they will sit at age 8 to 18 months, so huge degree of variability, stand at 9 to 20, and then we'll start walking at 12 to 33 months. So there's a definite delay in the time with which they're acquiring these skills. So I had a physician say, yeah, that's okay, but then they catch up. And we thought, well, do they? So if you look at what happens in childhood, when kids are school age, they're still not able to do certain things. So what's shown on the left is just a child's ability to stand on one leg. And our groupings below are going to be our kids with normal hearing. Here we have kids who have hearing loss who utilize a cochlear implant and have normal vestibular function, kids who have a unilateral loss and then a bilateral loss. And you can see that we have this nice stepwise function here where if you have hearing loss, you're still not doing quite as good as your peers who have normal hearing. But if you have vestibular loss, you're doing particularly poor, even in childhood. So no level of plasticity is helping you with your gross motor skills. The BOT2 is a standardized test of gross motor function, and similarly, we see a stepwise function where even our kids who have implants and normal vestibular function are not doing quite as well as their age-matched peers with normal hearing, but that function gets progressively worse the more severe our vestibular loss is. And just to kind of highlight this group here, as I said before, one of the things we're concerned about is what's happening in these children who have implants, who have, quote, normal vestibular function and some underlying reasons in terms of why their balance function isn't like their normal hearing peers. And we'll talk about that later. This was a study done by Rosemary Ryan in 2000, and to my knowledge has not been replicated, but basically what she did is she took this group of kids who had vestibular loss and she put half of them in a PT program and she waitlisted the other half. Well, she did a pre-test for everybody, and then for the waitlisted, she tested them again without receiving any physical therapy, and they declined in their overall function. And so, I always kind of highlight this, that I think plasticity is a great thing for kids, and they're learning a lot of stuff in their development, but it doesn't account, can't compensate for everything. And so I think we need to be paying close attention to these gross motor skills in these kids and not assuming that just because they're late to meet their motor milestones that they're fine after that once they learn to walk. This paper was published in 2015 that's central to children who have cochlear implants. So we know that kids who have vestibular loss have imbalance. And so what this paper looked at was the relationship between imbalance and cochlear implant device failure. So here we have our typically developing children. Here we have our patients without CI device failure. You can see we still see this reduction. And then our children who have CI device failure, and what's shown here are scores on that standardized test of balance performance. And so the kids who have CI device failure are the kids who have the worst balance. So in this paper, they sort of surmise that if kids are more off balance, they're probably more likely to experience falls and hit their head. And that could be one reason why they're having device failure. Now, there could be another million other reasons for this association, but this is sort of the leading hypothesis at this time. And I think this, could use a little bit of follow-up. To my knowledge, there are not studies out there that are documenting children's risk of falling and looking at overall imbalance in everyday activities. So more to come on this. like I said before, there is a new area looking at cognitive dysfunction in adults who have vestibular loss. So typically what's been found is that in adults who have vestibular loss, there are reductions in spatial navigation, spatial memory, visual spatial attention, executive function, and cognitive processing, but very little has been done in children. So part of studying cognition in adults is that we have to keep in mind that we have the aging process superimposed on having vestibular loss. And in children, we don't have that. So here we have this sort of developmental component. But the other thing we talked about is that kids who have vestibular loss typically will have hearing loss. And so that's something that has to be taken into account. So in terms of the literature review that I've done, I've noticed 3 studies that have investigated whether children have similar cognitive deficits as adults. And one of those was a study that we published a couple of years ago. So we were interested in knowing whether or not children who wore cochlear implants, who had vestibular loss, if they had poor working memory function compared to their peers with cochlear implants who had normal vestibular function. And I should preface that by saying that it's been well documented in the research that children who have hearing loss and utilize cochlear implants have poor working memory. So we investigated verbal working memory and visual spatial working memory. And our groups here are children with normal hearing, those with implants and normal vestibular function, those with unilateral loss, and those with bilateral loss. And we had a small group here. So statistically, the group who had vestibular loss did not have significantly worse working memory performance. But in some of our subtests, you can sort of see this same stepwise function that we see with the gross motor skills. So a couple take-home messages here is that 1, you'll notice that the error bars are huge. There's a huge degree of variability, which means you need to have a lot of subjects. And one of the overarching themes I'll talk about today is the difficulty in recruiting children with vestibular loss because it's not routinely being assessed. But the other thing I'd like to point out is that some of the literature is not including a comparison group with a matched hearing loss and normal vestibular function. So one of the things, and I just took out our kids here who had normal function or even unilateral loss. And if we didn't include that control group, it's really easy then to see, oh yeah, vestibular loss contributes to working memory. But if you add those kids back in, it tells a completely different story. So I say that as we, are building our studies and as we analyze work that other people have done to make sure that we're keeping in mind all of the factors that can be accounting for some of the all of the variables that can be accounting for the factors that we're studying. So this is a second study that was published by the group in Belgium who looked specifically at emotion recognition. We have our typically developing kids in the middle, unilateral vestibular loss and bilateral vestibular loss. And you can see that there's a marked difference in their ability to complete emotion recognition tasks if they have really no vestibular function. But I will point out that there isn't a control group here with matched hearing loss and normal vestibular function. So that's definitely needed. So one of the overarching questions that we ask in the lab is, okay, so a child can't see when their head is in motion and they're acquiring skills later and their gross motor function isn't very good. Like, what exactly does that mean? And, I come across this a lot in my clinical work as I'm counseling patients when I identify vestibular loss is, we kind of talk about the things that we know, and I talk to parents about this gross motor issue, but what's unknown is what are the cascading effects? So if a child can't see when their head is in motion or they are feeling off balance, like what does that mean to the child? And that question hasn't yet been answered. But I think this study by Jennifer Braswell Christie sort of starts setting the stage for looking at other factors that could be affected by some of these things that we know. So this study was done, I think, in 2004, where she investigated reading skills in children who had vestibular loss. So here we have our healthy controls, our children with sensory neural hearing loss, and then our children who have sensory neural hearing loss plus vestibular dysfunction. And there are a couple things to note that children who have vestibular loss need larger print size while reading. So your critical print size here is just the print size that you need to do accurate reading. And then the reading acuity is the smallest print size that you can see while reading sentences. So we took a close look at this study And we had some questions. We wanted to know, did you control for other factors that can affect reading? So did you control for audibility, speech outcomes, language outcomes, cognitive outcomes, age? Because we know that reading ability can be affected by all of these things. And so that led to a study that we're doing now where we're looking at reading and cognition and quality of life outcomes in children who have vestibular loss. And I will say that we're controlling for all those factors. So we're making sure that the kids are matched on speech, they're matched on language, they're matched on audibility, and that they're matched on nonverbal intelligence. And we're not done with the study, but these are some of our preliminary data here. So we have our kids who have normal hearing, normal vestibular loss, but cochlear implants, unilateral loss, and bilateral loss. And you can see here that when we look at critical print size, the kids who have bilateral loss need a significantly larger print size for reading. We see this nice stepwise function where kids need this is for reading acuity, sorry, where they continually show that they need larger print size during reading. And then we took it a step further where we wanted to know, if you have a hard time seeing the print, does that affect your overall reading comprehension? And interestingly, if we kind of leap over here to D, we're seeing that it doesn't necessarily affect their comprehension, but I will say we're not done with data collection. But we see this interesting stepwise function as it relates to listening comprehension. So we're also looking at eye tracking to understand the mechanism behind this. So is it an eye movement issue? Or is it a cognitive issue due to the presence of that vestibular loss? And so we're in the process of collecting data for this study. If you know of any kids who have implants who want to come participate in this study, please contact me. We need 10 more kids with vestibular loss and 10 more kids who have implants in normal vestibular function. But one of the issues we're having is we're having a really hard time recruiting. And we're having a hard time recruiting because labs are not checking vestibular function in their kids with cochlear implants. So this was a poster presentation done by Elena, and I are good friends. She works in California State University. And they did a questionnaire where they just asked pediatric providers, are you testing vestibular function, in your patients? And 58% said no. And I could tell you that that's the case because we're trying to recruit people for our study, and I have contacted our surrounding states. They're not checking it in South Dakota. They're not checking it in Minnesota. They're not checking it in Iowa, Missouri, Kansas. The only state where they were is at Children's Hospital in Colorado. So that limits my ability to answer these questions in terms of whether or not we need to be paying attention to it. It's really hard to recruit kids. So with that, we've come up with some screening things, which I'll get to in a second. But there was a study that was just published recently that we'll talk about here in just a second, talking about just epidemiological factors. But I really liked this quote. So I put it in the presentation where they say that the study of vestibular imbalance disorders in children and adolescents is still developing, which it is. There's a lot of work that needs to be done to determine how vestibular dysfunction is affecting these kids. But they say that nonetheless, early diagnosis of these conditions in children may prompt recognition of and remediation for the known impact of vestibular disorders on gross motor development, learning, cognitive skills, and school performance. So I feel like even though the work hasn't been done, we're at a point where we could be screening these kids at minimum and getting these kids involved in vestibular rehabilitation. So my sort of take-home message in terms of understanding the consequences is that more research is definitely known. We feel like it's well documented that these kids can't see during head movement. It's well documented that they are having imbalance in gross motor dysfunction, but what's unknown are sort of these cascading effects. And I think once we define that, then that will sort of push clinics to be screening for this a little bit more readily. So what are 5 things you can do to screen children for vestibular loss? We're going to talk about that today. So you need 5 minutes in your clinical practice to tell whether a child is at risk for having vestibular loss. Before we get there, though, I'm just going to take a second to talk a little bit about just some epidemiological studies that tell us about just the overall prevalence of vestibular dysfunction in kids. And there have really only been 3 key epidemiological studies. One was published in 2010, and they showed that the incidence of vestibular dysfunction was about 0.45%, so not very prevalent at all. But they did highlight a couple of what I consider really important things. That one, children were 43 more times likely to have a sensorineural hearing loss if they had some degree of vestibular involvement, and that they were 16 times more likely to have a headache involved. But what was striking to me in this study is that 90% of the kids were diagnosed as having unspecified dizziness, which means we're not doing a good job of practitioners of assessing and diagnosing these kids. So a lot of work needs to be done in terms of improving our overall assessment and diagnostic techniques. A second study was published 6 years later in 2016, and here the prevalence now has increased. So now we're looking at 5.3%, which is much more than 0.45. And so they highlight a couple important things. There's a slight female preponderance, so a little bit more females than males who are reporting dizziness and balance problems, and that the prevalence increases with age, which isn't necessarily surprising as you think like kids are going to get older and they're probably more likely able to verbalize that some of the symptoms that they're having are abnormal. And again, reiterates that hearing loss increases the chances of having dizziness. So this was a third study that was just published. It was either earlier this year or late last year, I can't remember. And there are a couple important things I think that are highlighted. So I like this because they looked at not just kids, but across the lifespan. So we can look at differences between children and adults along with similarities. So I'm just highlighting here a couple important things that we learn about children, which is that the proportion of peripheral disorders increases with age. And as we look here, that's the orange line here, that there is the presence of peripheral vestibular disorders in kids, one, and two, that we see this rise with aging, and two, that central vestibular disorders are shown in blue are significantly more prevalent in children, and then we see this sort of decline over time. And these trends are kind of mediated by a couple of different factors. And the first one is vestibular migraine. So vestibular migraine is a huge issue in children and very prevalent. And so this shows a couple of things. One, it shows this female preponderance. So females are shown in red and males in blue. And then just shows how prevalent that is in children compared to adults. And so from a practitioner standpoint, when a child comes in and is complaining of dizziness, the first thing we do is get out our clinical criteria for vestibular migraine and try to rule that in or out, because that is usually the number one reason why kids are coming in to be seen for dizziness. They took the top 3 diagnoses in each age category and sort of plotted them out over age. And I'm not going to spend a lot of time here other than to say kids can have the exact same underlying etiologies of dizziness as adults. And so just to keep that in mind, and that the prevalence mix is just a little bit different, and that we're a little bit more highly weighted for vestibular migraine in children and less weighted in children for Meniere's disease. So here this shows the prevalence of Meniere's disease for age, where it's almost non-existent in childhood and then really peaks in adults in the 30s to 50s. And then the same thing for BPPV, that it does exist in kids, but is significantly more prevalent in adults as we get older. So the take-home message here is that these epidemiological studies really tell us a couple of things. That one, we have 2 groups of kids who have dizziness. Kids who are reportedly having dizziness, and the prevalence mix can kind of vary, but roughly is the same as adults. And then we have our children who have hearing loss, who are typically not reporting dizziness, but have some degree of vestibular dysfunction. So the question then is, are all children who have hearing loss at equal risk for having vestibular loss? Okay, so now we're going to kind of get into my 5 in 5 minutes. So what are 5 things that you can do? One, when a child comes in, ask them if they're having complaint of dizziness. And you don't even have to ask them, you just have to have a questionnaire. And I would highly recommend taking the diagnostic classifications for vestibular migraine and incorporating those components into your questionnaire so it becomes easier to pick these kids out. But again, just to highlight that the etiologies in children can be the same as adults. This is etiologies by prevalence from the Manual of Pediatric Vestibular Disorders, and is really just to hit home that vestibular migraine is at the top, and that all of these etiologies can be found in adults. So we kind of can keep our practitioner hat on, but know that, again, the prevalence mix is going to be a little bit different. 2, when a patient comes in, do they have sensorineural hearing loss? That's pretty easy as an audiologist because we're routinely checking their hearing. So that takes like 2 seconds. Is it sensory neural hearing? Sensory neural? And what is the degree of that hearing loss? So you're more likely to have vestibular involvement if you have severe to profound sensory neural hearing loss. So it's really quick, takes 2 seconds to look at the audiogram and understand the severity. There are specific etiologies of hearing loss that have been associated with vestibular loss, and I've listed these here. And we're not going to take a lot of time other than to highlight that really none of these etiologies show vestibular loss 100% of the time, which means that understanding the etiology is not necessarily the most sensitive predictor for identifying vestibular involvement, but can be helpful for just understanding if that child is at risk. So the other issue is that hearing loss etiology is really only known in, I would say, like 60 to 70% of cases. So there are quite a few kids where they come in and you have no idea what caused the hearing loss. So we need other factors to help us predict. So we know that, again, not all children with hearing loss have vestibular loss, but it's significantly more likely to occur in kids who have severe to profound, which are our cochlear implant kids. So there have been several studies that have documented the rate of vestibular loss in kids who have implants, and the rough estimate is that if a child is a cochlear implant candidate, there's a 50% chance that they have some degree of vestibular loss, and 25% of those kids will have bilateral vestibular loss or, almost no vestibular function. And I always cite this paper. I really like it because it's really easy to look that if we look at all of the different etiologies of hearing loss, and then we look at the different tests of vestibular function, so caloric rotational chair or vent testing, that just a quick cursory look at this shows you that 50% of the kids, regardless of etiology, are demonstrating some degree of vestibular involvement. We did a study in 2018 where we wanted to know if degree of vestibular loss was a good predictor and sort of what kind of sensitivity and specificity that yielded. So we had 2 groups of kids, children who wore an implant, and then children who were part of our neurosensory genetics clinic, which has now been rebranded as our pediatric hearing clinic. So cochlear implant kids, they're all going to have severe to profound hearing loss. They're shown up here. And then our kids who are seen in our pediatric hearing clinic had varying degrees of vestibular loss. But we found that if you just used a PTA cutoff of 66 dB, that captured all of our kids who had bilateral vestibular loss and really only missed some of our kids who had unilateral or mild to moderate vestibular loss. So not a perfect predictor, but just something to keep in mind. Do I look at the audiogram? Is it sensory neural? Yes. Is it severe to profound? Yes. Then that child is at risk. So recent research then has taken this data knowing that there's this association between sensory neural hearing loss and vestibular loss, and they're now starting to do pediatric newborn vestibular screenings. And so there are several really nice papers out there commenting on the feasibility of doing this. And so they're primarily doing this overseas in Belgium, but it does help set the stage for us in terms of who's a good candidate to be screening. But typically the way this is working in Belgium is that any child who fails their newborn hearing screening automatically gets a vestibular screen at age 6 months, and they're doing that using the cervical vestibular evoked myogenic potential test, which if you're not familiar with that, we put a sticker electrode on the neck, we turn the head to get that muscle to tense, and we play a loud sound that stimulates the balance center, and it causes some muscle potential changes. And that can be done, starting typically at day 1, but most often the testing is initiated at age 6 months. But this is sort of led us to say that we need to be screening any child who has severe to profound sensory neural hearing loss. Research from the studies where they're doing screenings in young kids has also shown that children who acquire their hearing loss or have progressive hearing loss are at increased risk for having vestibular involvement. And then, as we know, any child who demonstrates some sort of developmental delay. So as part of our retrospective analysis to look at whether or not hearing loss was a predictor, we also looked to see whether or not case history questions were predictors. So we went through to see at what age children sat independently and what age children walked independently. And as you can see in the figures here, we have these are all kids with hearing loss. We have our children who had normal vestibular function, mild to moderate bilateral. We still see this stepwise function where kids are Their age to sit becomes delayed the more severe their vestibular involvement, and same with age to walk. And then we just investigated what different cut points were and what the sensitivity and specificity was. So for these different gross motor skill markers. And we found pretty good sensitivity and specificity for just simply asking parents, at what age did your child sit? And at what age did your child independently walk? And so we typically will ask that question, and we sort of use 7-ish months as our cut point for sitting, and then 14.5 months for our cut point for walking. And I always highlight that these fall within the normative range. If you look at the World Health Organization recommendations for normal development. So even if a child walks at 15 months, that might still be considered normal, but is a risk factor if they have comorbid hearing loss. We consider them a potential candidate for needing vestibular testing. We also looked at just asking parents, are you concerned about your child's gross motor skills? Takes 2 seconds. And if they said yes, then that a significantly higher proportion of parents who said yes also had a child who had vestibular involvement. So here are kids who had normal function. You can see that a significant proportion of them, the parents said, no, I'm not concerned. But if you look at our children who had bilateral loss, almost all of those parents said, yes, I am concerned about my child's gross motor skill acquisition. And so we have found that to be really helpful. So far, in about 2 minutes, we can look at the audiogram, look at the degree, to a degree and type of hearing loss. 2, we ask parents, at what age did your child sit? At what age did they walk? And are you concerned about your child's gross motor skills? So it doesn't take long. If there is continued concern, there are some really fast things you can do at the bedside. So for school-age children, you can do the single leg stance test. So you just ask the child, all right, I want you to stand on one leg, knee bent 90 degrees, put your hands on your hips. And when I say go, I'm going to have you close your eyes. And you just want to know, can that child stand on one leg, eyes closed for more than 4 seconds? If they can't do it for 4 seconds, they're at risk for having vestibular loss. It's so fast. So here's my son, he's 6, and he's able to do this for, once we get to 4, we just stop. I don't care how long you can do it. So it doesn't take long. So here's a test that takes 4 seconds. So not very long. But I want to just put a caveat in here that grumpy kids will do it. This is my 4-year-old. But that children really need to be at age 5 or up to do this. So what's shown here are normative values for children in terms of their ability to do this test. And you can see that it's not normal to expect a child, even at 5, to be able to do the single leg stance for 5 seconds. So typically we start this school age once kids get to be in kindergarten. And this is just to show you that they will do it. But it's, again, not a normal expectation that a 4-year-old should be able to do it. All right, so if you still suspect it and they can't do the single leg stance because they're 4, you can do a bedside head impulse test. This takes about 10 seconds. So you have the head tilted down 30 degrees, and then you just do high acceleration, unpredictable head impulses in the horizontal canal. And this is some great work that Jen and Christy did that shows that our sensitivity and specificity are really pretty high. Here's my son, he's 6. You just have him look at your nose. Sometimes I'll put a sticker on my face. Sometimes I'll have someone stand behind me with something that they can fixate on. And we're just doing, again, high acceleration head impulses. And here's my crabby little girl. She's even smiling during this. But most kids, I will say, will tolerate this with no problems. And we start doing bedside head impulses for kids at like 6 months. So here I am testing my son. I don't remember how old he was, but he looks like he's probably 7 months in this picture. It's a little bit trickier in kids. You have to be fun. You have to be pretty fast. But I would just recommend anybody who's seeing kids to incorporate these things into your everyday clinical practice, because it literally takes less than 5 minutes to look at an audiogram, ask parents 3 questions, do a single leg stance, and do a head impulse. But this just shows here how that bedside head impulse is related to degree of caloric weakness, which is what most of us are used to looking at. And if the caloric weakness is low, 0 to 22, so in our normal range, the likelihood of having a normal vestibular head impulse test is really pretty good, which makes perfect sense. And then as the degree of our vestibular involvement increases, we're more likely to see corrective saccades at the bedside. And so here's just a video of a positive head impulse. And you can see when she moves to the left, or excuse me, to the right, her eyes stay on target. And then when her head is moved to the left, there is a really brief second where her eyes go with the head and then they snap back on target. And typically what we'll do in those individuals is the video head impulse test, and this is what our data look like. The right side show that the eye and head move in an equal and opposite direction, so that vestibulo-ocular reflex is working perfectly fine. And in the left, where the eyes went briefly with the head and then had to snap back to target, this is what we see, where the eyes briefly go with the head, and then these compensatory saccades have to snap back to target. So if you go through this 5-minute screening and you decide that the child's at risk for vestibular loss, then you can send them to me, and I'm happy to test these kids. So we start testing at Boys Town at age 6 months. So I just put pictures up here of things that we do. We'll do the rotary chair. We have what's called this remote camera V-hit, which I'll show you here in just a second. And then we've started doing bone conduction cervical vent testing. So we're able to look at the majority of the rate sensors in the ear at children starting at a very young age to diagnose them early, which is really important for getting them enrolled in physical therapy from the get-go, and to try to combat some of these consequences of having, early onset vestibular involvement. So for the last 5 minutes, I'm just going to briefly review a couple of new things that we've been working on in the research lab. So one of them is this remote camera V-hit. So the remote camera V-hit has been used overseas for the last several years, and there are a handful of papers showing that it's feasible in children at age 6 months, and there's some really good normative data papers out there, but there hasn't been any work done in the United States because it's not FDA approved. Well, we were in a position where our research department had a little bit of extra money, and I said, great, I would love to buy this and try it out and just see how it works and if this is something that we think is really feasible in kids. So we bought it, and we've been enrolling kids who come through our pediatric hearing clinic just to see how helpful is this and how feasible is it. And of course, I bring my kids to work with me. But the camera sits right here and the kids watch a target on the wall. You'll notice that nothing goes on the child. There are no electrodes, there are no goggles, there's nothing. The child literally just has to sit there and watch something on the wall, which I make it sound easier than it is. And some days it is. It's like magic. Like we'll get little kids in there and I'm like, that was so easy. And then, of course you get kids in there and you're like, that was so hard. Like, why am I doing this? But the beautiful thing is that if kids can keep their eyes open and watch a target, you can get data in all of the canals. So my son was 5 here and my daughter was 3. She might have been 2 right before her 3rd birthday. And you can see she's smiling, she's having a good time. It's kind of awkward. We have a play partner that's in front that's like holding an iPad. We ask the kids, what kind of video do you want to watch? We're singing songs. And the kids genuinely have a good time. So I have just a couple cases highlighting how it's been pretty helpful in clinic. And so this is a 20-month-old male who had bilateral mild hearing loss and gross motor delay. So the hearing loss was not a risk factor for me, and I thought there's really not any way this child has vestibular involvement. The gross motor delay was concerning, but he has a pretty involved case history. So he has corneal delaying syndrome. He was born early. He was in the NICU. He has growth restriction, plagiocephaly, torticollis. So when they said that they had gross motor delay, I was like, we're good. We still did a cervical vent test, which you can see yielded beautiful waveforms. So I said the gross motor delay is because of all of the other comorbidities. We do not need to worry about vestibular involvement. So this was at 11 months. Well, at 20 months, the mom was like, there's just something else going on. Like he's just not learning how to crawl or walk. He's super delayed. So they really pushed for more testing. So we did this remote camera V-hit, and lo and behold, he has bilateral vestibular loss. So I went back to the literature and looked up this corneal delaying syndrome, and sure enough, it's associated with inner ear malformations that can lead to bilateral vestibular loss, which I was unaware of. And so we got him enrolled in some vestibular rehab that was specific to his vestibular involvement that kind of coincided with the PT that he was already receiving. I'm going to just skip this one and move on to this other case here, which is a 6-month-old female who had severe rising to moderate sensorineural hearing loss and profound hearing loss in the left ear, so red flag, and history of congenital CMV, red flag. So we usually do CVEMP as sort of our first tier assessment, and you can see that these were kind of weak, but they replicated, and we said that these looked good. And then we did this remote camera V-hit, and we saw that she does in fact have some degree of vestibular loss in her left ear, which is the ear where her hearing loss is more severe. So one of the questions we had is there's really no way to validate this in young children to see if we're getting similar findings with this remote camera as we are at the typical goggle system. So we had a student do a project a couple summers ago where we just took a bunch of adults and we ran them on the remote camera and then we ran them using the standard system. And as you can see here, we're getting identical results, which made me feel better in terms of testing the kids. That I knew that our data were valid and reliable and that we could kind of push forward. So that was really helpful. So what we have here are both control individuals and individuals with vestibular loss comparing our goggle system to our remote camera system. And you can see that we're getting, the same grouping no matter what kind of system we use for both horizontal canals and our vertical canals. So that's been really helpful. And kind of led us to conclude that this is a really helpful tool that we're able to use starting at age 6 months. It's feasible and it does provide some really nice complementary information. So those 2 studies have led to 3 other projects that we're involved in. Well, 1 that we're involved in and 2 that are grants are in submission. But one of them is that we've started using this technology in individuals with Down syndrome. So we received this, it's called a transformative R01 to study auditory and vestibular function in individuals with Down syndrome. And we've paired with the Cernic Institute in Denver, Colorado, where individuals will come in, they get a blood draw, and in that blood draw, they're doing what's called deep omics testing. Don't ask me what is happening with the blood draws, that's not my specialty. But we take our mobile RV, which is pictured here, and it has an auditory booth in there, and then I put all our vestibular function testing in there, and we're doing complete audiometric assessments, including middle ear stuff, and then I'm doing remote camera V-hit and VEMP testing in these individuals. So that's been really fun. And then we have 2 other grants that have been submitted using this technology in children starting at age 6 months. And then really briefly, we're starting to dabble a little toe into vestibular perception. So Andrew Wagner is a vestibular scientist who came to Creighton University, which is just next to Boys Town, who does a lot of work with vestibular perception. And so I wanted to know, can we do vestibular perception in kids, or is this an adult-only task? And then I had some questions just about what was happening in our cochlear implant kids who had, quote, normal vestibular function, but like I was showing in some of the slides, just like reduced function in some of their gross motor skills. And so I wanted to know if vestibular perception provided any insight for some of these trends that we were seeing. So we built a clinical protocol using our standardized rotary chair, and we just did a simplified test where the door was closed, they're in complete darkness, it's light tight, and we put a sound, like a 70 dB white noise sound in the back, and they were given a little controller with a right and left button, and their job was to, as soon as they felt the chair moving in either direction, key right or key left in terms of the direction that they were moving. And we just wanted to know, like, can we do this? And we also did some like functional tasks, which I'm just going to skip for now. And I'm just going to go to this slide here. So we tested 44 individuals. We have individuals who are controls, hearing loss and normal vestibular function, and then our vestibular loss group. And you can see that our vestibular perception data follow the exact same pattern as all of our functional metrics, and that we see this staircase pattern. So I had anticipated that, and let me kind of break this down for you. This is the chair velocity when individuals responded. So if you are a normal control, you can detect the smallest changes in that chair movement. I mean, right away. If you had vestibular loss, it took you longer. The chair had to move faster for longer before you were able to key into that. But what I thought was particularly interesting is that we have this group of individuals who have, quote, normal vestibular function, but abnormal, or maybe not abnormal, but just differing perception. So we have some other studies planned to investigate this further, but we found that vestibular perception, as predicted, was worse in individuals with vestibular loss. But we think that the vestibular perception is probably cueing in on some degree of subclinical vestibular involvement in these individuals who have hearing loss, and that we were happy that we could reliably measure this in children age 9+. So just to kind of circle back, here's what I hope you took away. One, if someone asks you, what are the consequences of vestibular loss? You can say, kids have a hard time seeing when they're in motion. They have poor reading acuity because of that. Their gross motor skills are delayed, and that there are potentially some cognitive outcomes and increased falls. If people say, oh, how can I predict that? You can say, great, there are 5 things I can do in 5 minutes. I can ask kids, are you dizzy? I can look at their hearing loss. I can look at the type and degree of hearing loss. I can ask parents, are you concerned? At what age did your child sit? At what age did your child walk? And then I can ask kids to stand on one leg, and I can do a head impulse test. If you are asked what is new and what is up and coming in pediatric vestibular loss, you can say this remote camera is coming and it's awesome. And we can test kids at 6 months and it should be FDA approved by the end of the year. And kids can do vestibular perception. And it could be that some of these kids who have implants have subclinical vestibular involvement that we're investigating. I always have to put a plug in for research that's being done at Boys Town. So if any of you are aware of kids who have implants who want to come to Omaha, send them my way. They'll do a reading study. They can do some spatial hearing studies with Ellen Ping in the Functional Hearing Laboratory. They can do some emotion recognition stuff with Monita Chatterjee in the Auditory Prosthesis and Perception Lab, and they get to go to the zoo. Put a quick plug in for the Pediatric Audiology Translational Research Conference that's happening in 2025. There's a virtual component, so you don't have to come to Omaha, but if you do, you can go to the zoo. And then always, I just want to acknowledge everybody who has helped out with all the studies we've done along the way. And thank you for your time. I'm happy to take questions.
We have the ceiling mics on.
Ceiling mics are on, okay. Are there any questions from the audience? One, that's your camera.
I want to thank you for a great presentation. It's so great to see more vestibular research.
Thank
We
you.
know so little about it. You noted that you see vestibular dysfunction in Waardenburg syndrome and in some other syndromes. And certainly there are some non-syndromic causes that are genetic for vestibular dysfunction. Since children are tested genetically, and I imagine they're also imaged.
Yes, for the most part, it kind of depends.
Okay.
I mean, on family choice. So we have families that will decline imaging or families that will decline genetic testing. So one of our initiatives is to try to get more families on board with genetic testing and imaging and make that more affordable and accessible to
Mhm.
them. So
When you have been able to do, say, imaging in a case where there's also a genetic etiology, are you seeing more vestibular dysfunction when you see temporal bone anomalies or?
it can be a mixed bag. So that's not something that we have specifically looked at, but we have a grant that's gone in that's investigating whether or not there are more changes in children who have inner ear anomalies versus kids who don't. So if that grant gets funded, we will be able to answer that question a little bit more precisely. But that's not a specific area that I've honed in on, but I think that's a good idea. I would say just from the literature that yes, children who have anatomical, anomalies are more likely to have some degree of vestibular involvement. Or progressions in vestibular involvement. And so we have another pilot study we're doing that's specifically with individuals with large vestibular aqueduct syndrome. And that can be super variable. And some of that, because the genetics are really variable, that's a progressive disease. And so we're finding that the results are kind of all over the place. So, and that's sort of one of the aims of that pilot project that we have for 2 years is to look at what are the factors that predict both hearing progression or vestibular involvement. So,
Thank you.
yeah.
We have a question from online that says, any interest in the effects of meningitis?
Any interest in the effects of meningitis? Yeah, always. I think it's hard to do work that's concentrated on one particular etiology because you have a hard time building statistical power and finding enough kids to enroll in your studies. So, we thought, oh yeah, we'll do the studies on kids with cochlear implants and that'll be no problem. But we're even having a hard time, finding kids with this broad spectrum. So I think in order to do work specifically on, children who have meningitis, I think that would have to be a multi-site coordinated event to really hone in on that. But yeah, there's a lot of interest in understanding how specific etiologies affect not only the periphery, but the central nervous system. So I take CMV, for example. Those kids have a wide degree of heterogeneity in terms of the degree of their hearing loss, the degree of their vestibular involvement, and then whether or not there's any, comorbid central nervous system findings. So my answer is always yes. I'm interested, but yeah, what the logistics look like can be very different.
I really appreciated the 5 and 5.
Oh.
I'm curious if you might speak to the challenges a non-vestibular audiologist might run into with that bedside head impulse and how they might train themselves up to do that, because it is technically challenging.
It is technically challenging, yeah. And that's probably the hardest thing and why it's the last thing listed. And I think that most people don't do. I think I'm probably so bold as to say that like most of our ENTs don't even do it in clinical practice. Like I might be the only one on staff that feels comfortable doing that because I've done it on and probably at this point in my career, 1 million people. But yeah, there are, I think, some technicalities and some training that would need to be involved to make sure that we're doing it safely and that like the interpretation is correct. So yes, you're correct. There's a definite learning curve with learning how to do that.